Hey everybody, so this is part 2 of lecture 2. I'm starting over with where I left off is substance use history. So basically, cover all of the history, especially you want to get some detail about history of substance uses that has been used in the last year. You may or not need to get a thorough history of any substance use that hasn't happened any longer than that, at least for a diagnostic sake. But overall, for any substances that they have been struggling with in the last year, make sure that you attain the age of first use and how that use has progressed over their life. Make sure to also get a sense of when they have used last. Maybe they last used the same day of this assessment. It's hard to say, right? You may get a sense of it by the symptoms you observe on them as well. Then just make sure that you kind of get a sense of the average use from day to day and roughly about how much they tend to use. This can be challenging depending on the substance to get a good idea of how much they actually are using, but just do your best to kind of get a rough idea of the extent to which their substance use goes on from day to day or week to week. I also want to know if they've had any prior substance use treatment or periods of abstinence where they've successfully been able to stay off of a certain substance. And then we want to know what actually helped if they have. Figure it out because this could be great tools for planning their treatment in the future. Then we want to know what the risks for relapse may be, what they've run into in the past that may have caused some of their relapses. Maybe they can give some insight into this. But basically, you want to know, this is kind of a motivational interviewing technique, which is asking, what are all the reasons that you use? So getting that information can be very important too, just to get a sense of it. Is this for pain? Is it for sleep? Is it for relaxing at the end of the day? All this will help you determine possible alternatives that they can use for pain management, or whatever reason it is that they're using substances. What else could they do instead? Then we want to, of course, get the family history of substance use and treatment that anyone else may have had. A really important part of doing a substance use assessment is getting collateral information from other people in that person's life. So this can be any secondary source of information that you use to get more information on their substance use history. It could be parents, teachers, probation officers, case managers, spouses. We want to try and avoid anyone who may be a friend or may be invested in keeping the truth from you, just because they may feel aligned to be loyal to their friend and not say anything that the client themselves would want to tell you. So try to find somebody who would give you an honest approach. And it's, of course, very important that you have you talk about this with your client ahead of time and have them give you permission if they are willing for you to communicate with certain people. Have to do a release form first. So when you're doing this, it's always good to just tell them that this is the norm. The agency you work at may or may not actually give you the time to do this. Some places may mandate that you do something like that, or other places may not. But really important thing to consider if you are going to be doing a substance use assessment fully. Then you move on to the mental health history. You want to, like before, get personal and family history of any diagnoses, treatment, progress, things that worked, things that didn't work for this person. And you also want to, through observations, identify any past and current symptoms that may be going on. Also, another important thing to keep in mind is this concept of advanced directives. An advanced directive is basically just a legal document that gives somebody else permission to make mental health and medical choices for this person if their ability or capacity to give or withhold informed consent has been undermined by their own condition. So basically we're saying if somebody is in active psychosis, they can no longer tell the difference between reality and hallucination. This person would not be considered functional enough to make their own choices about their medical life. And so somebody else would have to step up to make a rational choice for this person. Really because we don't know whether or not they can actually make that choice. So once again, some organizations may have you do something like this. Or others are more lax about it. Typically, this is something that a primary care physician is going to run through with a client, so you don't normally always have to worry about this either. But sometimes it is very important to make sure, especially given somebody's mental health history, you'll get a sense for this. More often, this is for people with severe psychotic disorders or elderly who may be going through dementia. Of course, we want to get the social history. So this is really including everything else that this person's gone through. What was their childhood like? What were the economic conditions like? Was there any abuse, neglect, or trauma in their childhood that they may report? Then we want to get the social, academic, how were they in school? What subjects did they like more than others? Open-ended questions are really a great way to go for getting information in these areas. Were they in any extracurricular activities and how did they feel about them? What kind of important relationships are there in their current life, or maybe people that's been in their life for a long period of time? You also want to get work history and legal history. Some people might put these into separate sections, but I feel that all this can really all fit in social history. And you want to get medical history, any pre, peri, or post-natal complications. So did they have any problems during pregnancy, during birth, or directly after birth that you noticed, any early developmental stage difficulties? Really all you need to get for this is learning to walk, crawl, talking, all those kind of basic things. What was their general mood and disposition like as a baby? This can also give you some general information on how much their parents told them, because they're not going to remember a lot of this stuff. So this will give you a sense of how much their parents may have been paying attention and how much their parents shared with the client about what their childhood, what their infancy was like. Now, of course, you want to know about any specific medical conditions, diseases, or illnesses. Are they taking any prescriptions or medications right now? With their permission, you could also check their prescription history on something called MAPS. I don't really go into how to access that here, but just know that that's available, and some agencies may have you use MAPS. You also want to know what worked for their medical conditions, any forms of treatments that did work, didn't work, what kind of side effects they may be dealing with. All of that can be important to include in the medical history. Then it's also good to know whether or not they've had a physical exam done in the last year. Many people may not even know that they have a particular medical disorder because substance use can cover this up. For instance, I had a client once who was addicted to opioids, painkillers, and she didn't realize that she had a ulcer in her stomach until gotten at least a month or two of sobriety. Then she was actually able to experience the pain and nausea that came with the ulcers and was able to get them treated. So medical history can oftentimes interact with substance use in very unexpected ways. Then, of course, we want to identify what the problems and needs area are for this client. What focus areas can the client agree on with you? What do they want to work on? Is the medical area what they're most focused on, the mental health? You may have a lot of ideas of things that they should or could benefit from improving, but we really want to make sure that we understand and create a collaborative compromise on what's actually going to be focused on, because this serves as the groundwork for creating an agreed upon treatment plan. We want to go into strengths and protective factors. Basically, protective factors can be any kind of internal strength or external resource. So keep that in mind. Protective factor is kind of an umbrella term. Strengths can be internal, resources are typically external. And so we have a whole list of things that you can draw on to kind of create or consider for people. Social support, friends, family, peers, work, church, interpersonal skills, assertiveness, resourcefulness, knowledge of where to go and how to get it, and the initiative to do that. What kind of resilience have we seen this person develop just because of the things they've survived or experienced already in their life? We also want to make sure to include any prior successful treatments, times they've gotten sober in the past. We want to look at that as an internal strength too. They've done it before, and we're going to help them do it again. Sources of motivation for change, I'll talk about that more later. Any skills or talents, hobbies, recreational activities they like, and financial status, insurance, transportation, and whether or not they have a job. This can all be different types of protective factors, and good to keep in mind. So you really want to be able to assess for what type of motivators for change they actually have. And be aware of the interplay between intrinsic and extrinsic motivation. Extrinsic motivation is things that motivate them externally, right? Consequences for their behavior outside, in the world around them that motivate them to go to treatment. Intrinsic, the best way to put it, is that sense of fulfillment or gratitude somebody gets inside simply for doing something they enjoy. What you want to really keep in mind is if we add extrinsic motivation to something, that may get somebody to start doing something, but if they're already doing it, and they're doing it purely intrinsically, and then we add an extrinsic motivator to it, that can interfere with their intrinsic motivation. For instance, if you like acting and you've acted in community theaters for a long time, suddenly you get a job as an actor, and you may find that being paid for it makes it less enjoyable. That's just the way our brain works. It's called cognitive dissonance, and we can talk a little bit about that later too, perhaps. But just keep that in mind with your client, that sometimes being externally motivated will greatly interfere with their intrinsic motivation to maintain change. You're going to see this a lot with people going through probation. I could talk a lot about that. Let's see what's something at the end there. Also linked with reasons. So yeah, oftentimes the motivation for change will be linked to why they came in the first place or who referred them to treatment. So stages of change are very critical. I'm going to run through this pretty briefly, but a lot of time can be spent on talking about stages of change. Basically, there's about 6 or 7 stages, depending on when you who you read this from. Termination stage has been added recently, so I kind of include that here. But here's the stages. Pre-contemplation is when the person doesn't acknowledge that they have a problem yet. Contemplation is when they have acknowledged or admit that they have a problem. They're willing to maybe start making changes, but there is no commitment yet to change. Maybe they've done some little things, right? But they're not yet really doing a whole lot. They may have a plan to start doing something in maybe 6 months, but it has to be sometime down the road, right? They're not really thinking here and now that they're going to make any drastic change. Preparation stage. They admit there's a problem, and they are making a plan to change it. They are going to do something committed to make change happen within 1 month. Keep that in mind. 1 month, right? That they are planning to make real change in their life to improve something. Action stage, they're doing it. They are engaged in the plan, and that plan may be very involved. It may entail daily AA sessions, Alcoholics Anonymous. They may be going to see a therapist every week. They may even be committing themselves to residential treatment. They may be just visiting their family more often. There's a lot of things that may be a part of a full action plan, which is part of what you make with your treatment plan. After a while, after maybe a couple months of being in action stage, oftentimes people will begin to consolidate and reduce the number of things that they're doing or committing to as part of their change plan. That's when they're entering maintenance stage. Their symptoms may be reducing. They've been committing successfully to a good action plan, and they're just doing a little bit less than usual. And they're kind of pacing themselves a bit more. Maybe they're only going to AA sessions 2 or 3 times a week at that point. Relapses can occur, and they should be expected, a normal part of the change process, especially when we think about substance use disorders. We have to be able to also live and respond to when symptoms come back. That is part of a successful treatment, and it needs to be expected, because one thing's for sure is that shame and guilt of a relapse does not help. And so we have to view relapses as more positive once one happens, so that we can get through it and just move on with recovery. Termination is, of course, after the maintenance stage and when they're basically done with treatment, with us at least clinically, and they're just going back to their daily living to an extent. A couple things to keep in mind. One person can be at different stages of change for different disorders. For instance, someone could be in the action stage for trying to get their depression treated, but they're still in contemplation stage when it comes to the alcohol use that may be interacting with their depression. So that adds a whole nother layer of complexity to treatment planning, is deciding how you're going to address which treatment or which disorder they may be experiencing, and what tools and techniques you're using to help with different disorders that are at different stage levels of change. Also, another thing to keep in mind is this question I have down here is, what do these stages assume in order to apply? That's something we can easily overlook. And what's easy to overlook is that these stages assume that there actually is some kind of disorder going on. So that's something else very important to keep in mind, that stages of change don't really apply unless there actually is some kind of disorder present that we have to be able to determine is actually there. Another thing to keep in mind are these phases of treatment. Phases of treatment can kind of overlap with stages of change, but stages of change are all internal. These are, when we look at stages of change, this all has to do with the thought process and goals of your client internally. Phases of treatment have also much more to do with what they're actually doing with you as a therapist or as a treatment provider. So engagement, searching and connecting with various service options. So interesting. I find it ironic they say engagement for this first one because they're not actually engaged in the treatment process itself yet. They're just kind of still looking for services. Persuasion is the first few weeks that they're actually seeing a therapist and they're trying to determine what they actually want to do. They're negotiating basically with a therapist to determine the course of treatment. Active treatment is kind of like the action stage. Action treatment is when they are engaged and they're doing this, and I think this also kind of includes a bit of the maintenance stage as well. Then the bottom here we have relapse prevention, which is also a bit of maintenance as well as the termination stage, and may include relapses themselves. So we see how these stages can overlap a bit. This is just a different perspective on how to look at these stages. All right, so this is probably a good break point for part 2 of lecture 2. I'm going to stop here and then start up with safety assessment next.